Morning, Miss Brooks. This is Susie from SafeWatch. We're just another pair of eyes for the nurses and the doctors down there. You glad to be out of that bed?
From this floor at Mercy Hospital in Creve Coeur, Missouri, physicians and nurses monitor intensive care patients from all across the Midwest. This telemedicine program is called SafeWatch, and it's part of Mercy's EICU. Using today's technology, these caregivers are a second line of defense.
It really is remarkable what one can do with the technology when it is put in place, when the infrastructure is put in place. As an example, in the ICU, which is probably the highest intensity of monitoring that one normally sees, if a nurse walks out of the room, it is possible for the respirator to fall off. It is possible for the IVs to stop, and that certain warnings don't trigger for seconds to minutes. Whereas on the other hand, if you're being monitored through the EICU, it is almost instantaneous when that safety measure is noted and corrected. The technology is so remarkable that you can take the camera and focus down to the pupils of the patient, down to their pupillar dilatation as to whether or not there's any changes in the patient's condition.
Mercy SafeWatch started in 2006. Its success has led to a proliferation of telemedicine programs. Today, more than 70 are in motion.
This is Susie from SafeWatch.
I want to go over the results for your last ultrasound and talk about your...
Here, maternal fetal medicine specialist Dr. Jim Bartlesmeyer connects with a pregnant patient worried about a recent decrease in fetal movement.
Of the last ultrasound you had, and everything's looking great. The baby is growing normally. If you have a nurse on the other end, she can do part of the physical exam if need be. Obviously, sonographers are doing the ultrasound. Nurses may also be doing other fetal monitoring. And so we're able to pretty much provide every degree of care that I would have been doing a consult here in the office if the patient were sitting next to me. These patients are in communities where there's not subspecialty care available, such as us. So they would have to travel and take off work for a full day. Plus, a lot of times they have to do follow-up testing, fetal testing, on once or twice a week. So it's a great convenience to them. Plus, they have ready access to us.
Mercy's a relatively good-sized organization situated through the Midwest. We have 35 hospitals, a couple thousand fully integrated physicians, 700 advanced providers, 300-plus clinic sites. And we've been on a 10-year, roughly, intentional transformation to, as we say, get healthcare right, to build a new model. And it's not hard to understand if you think, I want to have people think about it incrementally as well as disruptive. On the incremental side, SafeWatch, which is our EICU program, or any number of continuous 24-hour-a-day monitoring programs, we can fill gaps. We can be at the bedside when somebody else is not. And the interesting of what we found, even when we had 24-hour intensivists putting the EICU in place, the SafeWatch program, what we saw is a consistent trend that keeps improving to where our Apache adjusted, our risk-adjusted mortality is 30+% less than predicted. Our length of stays are much less than predicted. In that environment, by filling the gaps, reacting faster, we can give better outcomes to people. And we've taken the same consistency and done that across a number of areas. We've done it in sepsis, and we've moved from monitoring the first sepsis beds to, we're just approaching 3,000 beds across our system that are monitored real time, 24 hours a day. Now, it's just not about telemedicine, it's about what goes with it. If you just look and monitor somebody, nothing changes. Monitor with a complete rework of the workflow makes a huge difference. So part of our intentional journey is, how can we complete the care continuums inside of a hospital, make them work 24/7? How can we extend what our doctors, what our clinical teams do, and bring it to people where they are? Can we have patients who live in rural Arkansas get the same level of access to care as people who live in Springfield or St. Louis? And the answer is, in the journey, yes, we can get there. We can bring care to people when and where they need it. So if you think about the transformation that technology can enable, I have a tendency to think of a hospital as a place to bring providers and patients together with all the technology and resources so that we can build a care plan. And with that care plan, we can put an expert interdisciplinary team around that care plan. And with that, we can take a patient, for instance, with heart failure, #1 cause of hospitalization, who's coming in on the brinks of death perhaps, and 4 or 5 days later, we send them out relatively in good shape compared to where they started. We do that through pretty simple things: a team, a plan, monitoring against it, and making sure the right person is getting that person at the right time. I think in 5 to 10 years, we're going to look back and we're going to realize what some people have thought, which is that a lot of chronic disease, which is increasingly taking a majority of our hospital beds, that those should become ambulatory conditions. Because what do we do in the hospital? We put a plan together, we hook up to the patient, we monitor against that plan. When something triggers, the right person comes to the patient. I used to oversee an emergency room in a university setting, and we developed a neat program where we integrated our emergency room with our clinic, trying to create a continuum. And we did some pretty cool stuff. But what I realized kind of after the fact is a lot of times the person showing up in the emergency room who was going to get admitted for heart failure is somebody I should have seen 2 days ago. But I had no clue that I needed to see them. I didn't have the technology to do it. But with telemedicine, that technology exists. And so it's going to get better, it's going to get cheaper, it's going to get easier to use, but progressively it's a journey to move from a bimodal health system. And when I say bimodal health system, most of us are trained inside of a hospital, and it's incredible the care you can get inside of a hospital. But when you leave that hospital, you go from integrated, complete care to kind of reacted, fragmented care. So if you think about telemedicine a little different, about virtual care, it's the ability for us to extend our care teams from the institution to the patient, to take our patient-centric approach that we've learned how to do and get the highest value inside of a hospital. And why can't we make that patient centricity work 24/7, 365, with us proactively bringing care to a patient instead of waiting for the patient to come to us? It's not easy. It's a challenging solution to put it all together. If we could, for instance, make heart failure an ambulatory condition today, why isn't it being done?